Good morning, everyone. Do you hear me? I'm presenting from a remote location. So I'm going to present this morning the topic of cerebral venous sinus thrombosis, which is a very relevant topic, especially during these days of the COVID-19 infection. As you know, cerebral venous sinus thrombosis is a subtype of stroke that you don't encounter in a daily practice. So it's not a day-to-day practice that you see a patient with the cerebral venous thrombosis. And therefore, it can be missed or diagnosed late, and this is not good for the patient management. So the aim of this presentation is to be vigilant and aware of the stroke subtype, especially during the era of COVID-19. It has a heterogeneous clinical manifestation and not specific to the venous thrombosis itself. Imaging is the most important, especially MRI, plays a primary role in the diagnosis. And if you diagnose it early, it has a favorable diagnosis. So that's why you have to have a high index of suspicion for the diagnosis. And the mainstay, as you know, is IV heparin or low molecular weight heparin. And as I said, in the COVID-19 era, you should always think about CBST in patients presenting with neurological symptoms or headache. So CBST is caused by complete or partial occlusion of the cerebral major vessels or the smaller feeding cortical veins. It affects women mostly. 75% of patients are females, and usually young because these are patients of the reproductive age. It rarely affects people in elderly people. So the incidence of cerebral vein thrombosis in patients over 65 years old is 8% only. And as we said, it's associated with peripartum period and oral contraceptives. I'm going to mention two studies that done in Kuwait, in Ibn Sina Hospital. They have over 10 years collected 71 patients, and those patients, the oral contraceptives was the primary risk factor in female patients, and the early diagnosis and immediate treatment with anticoagulants reduced the morbidity and mortality. In this study, serum D-dimer is more helpful for early diagnosis with sensitivity of 58%. This study was extended after a few years and more patients were included. And the conclusion of that study is the headache, seizures, and focal neurological deficits were the most common neurological presentation. Anticoagulants were used as first-line therapy, even if there is intracerebral hemorrhage. The use of steroids and diuretics were used to decrease edema in 25% of patients, and those patients who had raised ICP were treated by serial lumbar punctures. CVT has certain risk factor, doesn't follow the classic atherosclerosis risk factor for arterial thrombosis. Around 13% of patients, they don't have any risk factor can be identified. The risk factor for CVT can be divided into transient or permanent. And transient in those patients, women who is using oral contraceptives or during pregnancy and postpartum period, or certain infections of the ENT, especially mastoiditis. Permanent risk factors include the thrombophilia and prothrombotic states. The risk factor for cerebral vein thrombosis in a study by Ferro et al. included, quickly we'll talk about those, gender specific, like the hormones, systemic infections like malignancy or inflammatory bowel disease or Behçet disease. Don't forget the Behçet disease. Always screen for Behçet by asking about orogenital ulcers, the genetic or thrombophilia. There are numerous infections, especially the ENT infections. Mechanical. Interestingly, CVT can happen after lumbar puncture. So be aware if the patient deteriorates after lumbar puncture that he may have venous thrombosis, head trauma, certain medications, and certain vascular, intravascular anomalies. As Dr. Badr discussed earlier, the pathophysiology of cerebral vein thrombosis is like the situation in idiopathic intracranial hypertension. There is a thrombosis of the veins and decreased CSF absorption, increase in the intracranial pressure, and disruption of the blood-brain barrier, and congestion of the veins. And there will be back pressure and hemorrhagic infarction. So this is peculiar for this kind of subtype of stroke. It's hemorrhagic. So it's very interesting that it's hemorrhagic, but still we're using the anticoagulation using heparin. For those who are not practicing this, they'll be initially very surprised how we're using anticoagulation despite the presence of blood or hemorrhagic transformation. This is the hallmark of CVT, that the presence of hemorrhagic transformation, and anticoagulation should be used actually. So the more common presentation of the CVT is isolated intracranial pressure, as Dr. Badr mentioned, headache with or without increased intracranial pressure, focal symptoms like weakness, seizures, encephalopathy. Patient is usually have altered mental status. You see those patients, young woman who's drowsy, having seizures, headache, vomiting. If you see such patients, you have to suspect CVT. A rare presentation of CVT is cavernous sinus thrombosis, and that has a peculiar presentation with cranial nerve palsy, cortical vein thrombosis, subarachnoid hemorrhage. We saw several cases of subarachnoid hemorrhage as part of the CVT, and the cranial nerve palsy, like 6 nerve palsy, related to increased intracranial pressure. This is the cortical vein occlusion, where in this case there are several cortical vein thrombosed and appear hyperintense on MRI. When you suspect CBST in patients with headache, usually you ask, there is a history of using hormones, or patient just delivered, or there is a patient with malignancy. A new type of headache, different from the patient habitual headache. Symptom and sign phrase intracranial pressure, a new neurological signs, focal, decreased level of consciousness, or seizures. You have to be familiar with the venous anatomy, because this is will help you in diagnosing or identifying the location of the vein thrombosed. So in this case, this is the severe sagittal sinus, this is the inferior sagittal sinus, this is the straight sinus, transverse, and followed by the sigmoid, which eventually goes to the jugular vein. This is an MRV. This is a coronal view, back view. We see there is the severe sagittal sinus, drains into confluence of sinuses, both transverse sinuses, draining into the sigmoid sinuses, where there is the mastoid. If so, there is mastoiditis, it will cause thrombophlebitis in the brain and cause thrombosis. So you treat those patients with antibiotics. This is eventually the internal jugular vein. So the clinical manifestation occur depending on the location of the vein thrombosed. The transverse sinus is the most common sinus involved, followed by the superior sagittal sinus, followed by the sigmoid, then cortical veins and cavernous sinus. Cavernous sinus involvement is the least common. So transverse sinus location usually causes nerve palsies. Superior sagittal sinus will cause visual loss, aphasia because it's close to the speech centers. Sigmoid is a combination of several cranial nerves palsies. So you should know the vein involved and the subsequent neurological symptoms. Neuroimaging is very important in diagnosing patients with cerebral vein thrombosis. You can start with non-contrast CT. Is usually in emergency room, usually you start with CT scan. Can be normal in 30% of patients. There are certain signs that can help you diagnose the patients. Empty delta sign and cord sign. You can see immediately the signs of ischemia by CT if the patient is presenting late. This is the classic empty delta sign. You see delta, which is a Greek letter, like a triangle. This is CT brain with contrast, should be with contrast. So you see filling defect within the distal superior sagittal sinus. And this is a classic teaching signs called the empty delta sign. You can see the cord sign on CT, which is a cord-like structure, can also make you suspect cerebral vein thrombosis. In this case, patient have bilateral venous infarcts, slight hemorrhage. Usually, if the superior sagittal sinus thrombosed, usually the infarcts are symmetrical or bilateral. Such patient will present with altered mental states and aphasia and seizures. CT venography or CTV. So if you see this patient in the ER and you see such CT, you should ask for CTV as an initial test. It has a very good diagnostic accuracy, high sensitivity, and specificity. It can show absent flow in the thrombosed vein or sinuses. And however, there is false positive. It can certain venous anatomy is not as variable, and certain patients have congenital hypoplasia, and this may give you false positive venous thrombosis. Usually, the venous infarcts are hemorrhagic, like in this case, can be bilateral. That is, here you can see thrombosed transverse sinus or thrombosed superior sagittal sinus. MR venography is the standard of care, and you can do it without contrast. Again, the high risk of false positive because of the variant. Actually, we see a inexperienced radiologist or inexperienced person dealing with such cases will overcall the case as cerebral vein thrombosis and unnecessary anticoagulation. So you should take this into the context of the patient diagnosis. You can do MRV without contrast in the time of flight or phase contrast. Contrast enhanced MRV needs contrast, of course, and this is more accurate and overcome the difficulty with the venous hypoplasia. The MRI is very sensitive. It can detect recent infarction by DWI and give you more details about the extent of infarct. This is how the deep infarcts look like with the hemorrhage by susceptibility weighted images. Beware of the hypoplasia, the chronic thrombosis. Some patients will have partial recanalization, but will not, if they have history of CVT in the past, they will still be, it will show later by later imaging. We rarely use the digital angiography. We don't use angiography for diagnosis. Only if there is isolated cortical vein thrombosis or there is associated dural AV fistula, you can use the digital subtraction angiography. The management of CBST includes looking for the etiological cause, starting anticoagulation, and symptomatic treatment of intracranial hypertension, seizures, or other complications. This is briefly the American Stroke Association guidelines. We should start with routine blood tests, look for prothrombotic conditions, postpone the thrombophilia workup until 2 to 4 weeks after completion of the course of anticoagulation. That means after several months of this, stopping the anticoagulation. Provoked CVT usually needs a course between 3 to 6 months. Provoked means after using oral contraceptives or after pregnancy or after delivery. If there is unprovoked, you should extend the course of anticoagulation to 6 to 12 months. If you have a patient with recurrent CVT or you identify a definite cause for thrombophilia, this patient needs indefinite anticoagulation. You can use low molecular weight heparin during pregnancy until 6 weeks postpartum. And you tell the patient that future pregnancy is not contraindicated. And you can use prophylaxis with low molecular weight heparin during pregnancy. D-dimer is used often for diagnosis of deep venous thrombosis or CBST. You can use D-dimer mostly as exclusion because it has high negative predictive value. So it's if the patient have only headache and he's fine, his CT is fine, and you do D-dimer, then you'll be more assured that the patient most likely will not have CVT, and you don't need to do further unnecessary testing. Anticoagulation, we said between 3 to 12 months, depends if this is provoked or unprovoked. There is no definite guidelines regarding whether you have, before stopping anticoagulation, whether you do follow-up CTV or MRV. There is, it won't change really the management. And there is no mention of the use of antiplatelets after CVT. Anti-epileptics are used with supratentorial lesions or if the patient presents with seizures, and those requiring longer-term anti-epileptic if there is a residual lesion. This is, in summary, the algorithm for patients with CVT. So if you ideally should do MRI. If you cannot, you do CT, CTV. If you don't find CTV, look for alternative diagnosis. If you confirm it and you start your anticoagulation, patient improves, then use the anticoagulation for several months, then stop. If the patient deteriorates, then think about decompressive craniectomy or interventional radiology. There is a trial about use of dabigatran. Of course, you will think not only warfarin will work for such patients. So new oral anticoagulants can be used. So in this case, a study about dabigatran 150 milligrams twice daily compared to warfarin. And the study showed both are safe and cannot be, we cannot demonstrate non-inferiority or superiority of either treatment. There is ongoing study about the use of rivaroxaban compared with warfarin to see if there is any still works like dabigatran. The duration for anticoagulation still need to be defined exactly. So there is ongoing trial about the benefit of extending oral anticoagulation treatment after CVT, and the EXCOA trial is still going regarding the definite duration of anticoagulation. Endovascular treatment is used rarely, as we said. It has a rate of intracerebral hemorrhage of 10%, little bit higher mortality. Thrombolysis is not used. We only consider endovascular treatment in severe cases, like those who do not improve with anticoagulation, and especially if you do the intervention early in the course of the disease, not late. This is hemicraniectomy. You see here there is a big hemorrhagic infarct with midline shift. In this case, the decompressive craniectomy helped the patient, saving the patient from herniation. The prognosis, overall prognosis, is improving. And a third of comatose patients have a full recovery. This is the last part of the talk about CBST and COVID-19 infection. As we know, thromboembolism is part of the COVID-19 infection, and a hypercoagulable state can be seen late in the COVID-19 infection, even if
Dr. Sama, 1 more minute remaining.
Okay. Then the patient can present late due to potential association. We'll talk about the vaccine. As you know, the Johnson vaccine and the AstraZeneca were associated with a new vaccine-induced prothrombotic immune thrombocytopenia. This is a rare and a new syndrome. It's called VIBIT or TTS, and the patient have present with CVT, and that's why the CVT gain fame during these days. The patient will present with headache or abdominal pain if they have splanchnic venous thrombosis, visual changes like CVT. And it's so uncommon. It was not observed during trials, observed when the actual vaccines started. So it's very rare, like less than 1 in a million. So the American Stroke Association, American Heart Association advised to continue to urge everyone to get vaccination, but beware of those who have hypercoagulable state and older patients. And definitely the benefits of vaccination far exceed the very small rare risk. In summary, CBST is rare, but clinically serious and can result in substantial morbidity and mortality. The causal factors for arterial thrombosis is not there, so you have to suspect it. MRI plays a primary role. COVID-19 should be considered as one of the differential diagnoses of cerebral venous sinus thrombosis. The likelihood of developing CVST after a vaccine is extremely low, so you better get vaccinated to protect against all the complications of COVID-19. Thank you so much.